I'll carry on. So we're about, in total, about 180 participants from 11 countries. We've moved, that's okay, we've moved on a bit. 11 countries. I think there's about, yeah, just go back for me. Oh, that's okay, go forward, that's fine. So what are our aims today? We're going to present the data from, there we go. So at the end of OMERACT 2023, we aim to have updated the whole group as to the status of our subgroups, and also voted on ultrasound as a validated tool for synovitis and enthesitis in inflammatory arthritis using psoriatic arthritis as the target disease. So we're hoping to vote today or at this OMERACT on ultrasound as an outcome tool for synovitis and enthesitis. Our goal as a group is to validate musculoskeletal ultrasound as an outcome measurement in rheumatic musculoskeletal diseases. And we were established in 2004, as mentioned. We did an SLR on ultrasound as an outcome measure according to the OMERACT filter, well, the original OMERACT filter. And we found that truth and feasibility were good, but discrimination was lacking. So then we went on to focus on the discriminant validity of the instrument. And as mentioned now, we're up to 185 members working across 5 continents in 11 different diseases. You can see down the left-hand side there. And there's 18 active subgroups. These are the active subgroups. We're going to present data from a few of these subgroups today. So this is about, I'm just going to now talk about 3 papers which are really our key achievements over the last 15 years, or more than that, since 2004, I guess it's 19 years now. So this is a paper by George Brunn, which really lists what we've achieved over the time to date to the 15 years. And it talks about pathologies and elementary lesions and includes all the definitions of all the diseases we've done, which were up to date at the time. So that's quite a nice place to find all of our information. We've also been quite working on our methodology over the years. OMERACT is an iterative process, I guess, and we've contributed to that in terms of methodology. So the OFISA is the OMERACT filter instrument selection algorithm, and we have worked on developing this with regards to imaging, but it can also be applied to other tools such as PROs. So the special interest for imaging is that there needs to be consensual definitions of what should be measured. And we also need to think about the variability of reading. And variability, particularly with regards to ultrasound, is specifically important with regards to acquisition and interpretation. And it's something that's been really critiques of ultrasound have focused on a lot over the years. So we've worked really hard to look at image acquisition and interpretation of the items. We also need to think about the impact of using different equipment, which implies a lack of information on the impact of the technical performance on the information retrieved. So if we look at the specific lessons learned, these are outlined in this paper, and there's really 3 main lessons that we want to take away from the imaging methodology, which are applicable to all instrument selections. And so the first is to reinforce the importance of domain definitions as a foundation for instrument selection, so the domain match. So if we look at the choice of target domain, firstly, that should go back. We need the core area, which from the domain perspective is the manifestations or abnormalities. The broad domain, so what we want to measure, which in the case of synovitis is inflammation. The target domain, so what we focus on, is synovitis, and the domain components, that is what we can actually measure, are synovitis elementary components. So if we consider the choice of instrument when we're selecting an instrument, we consider the technical perspective and then the instrument perspective. So this is the technical perspective is joint inflammation detectable by ultrasound, and that is also the instrument perspective. However, the target domain is synovitis detectable by ultrasound, and then we create a theoretical definition that is synovial thickening with increased blood flow. The ultrasound detected elementary components of synovitis need an operational definition, which is hyperechoic synovial hypertrophy and increased Doppler signal within the synovial hypertrophy. So this is established through doing a systematic literature review to review the evidence. We do a Delphi if there's not evidence to agree on the definitions, and then we perform a reliability exercise on static images, and that's how we come up with our operational definitions. So the second lesson learned is that we need to understand the importance of the sources of variability in measuring and how they influence our outcome measurement instrument. So imaging is more than, the outcome tool is not the ultrasound, the outcome tool is the score. So we need to look at the variability that can affect that. And these can be random. Here, sorry, I haven't got a pointer. Which are sources of, which affect the accuracy or the reliability, the precision or the reliability, and create noise. So it's very important to ensure that everyone is properly trained and there's standardized acquisition techniques and understanding of the protocol. And then you can have systematic errors which create bias, and that affects the truth or the validity of the tool. So you need to work on making sure you have very good definitions and quality equipment that's appropriately calibrated. So we really need to think about the quality of the process of developing the outcome tool, because that affects the validity and the reliability of the tool. So then the third lesson we wanted to demonstrate that we've worked on is that how these first two lessons should be applied into the OFISA to help with the process of developing an outcome tool. And this is where they fit. So level 1 is domain match, and that fits in the arrow there. Is it a match with the target domain, e.g. truth? And then the sources of variability also affect truth, where it's indicated there. So OFISA, with just a couple of improvements, can be applied to imaging outcome measurement instruments, but they can also be applied to other instrument tools such as patient-reported outcomes in exactly the same process. This other paper, which is another one of our key achievements, is the demonstration of the stepwise approach of the OFISA. So step 1, checking the evidence. So this is usually a systematic literature review. Step 2, developing consensus in developing the new definitions. Step 3 is about testing techniques and looking at internal validity. And step 4 is about developing the evidence. So now we'll move on to updates from our working group. And unfortunately, I'm going to keep talking, so going to get used to my voice, and then we'll invite some other members of the team up to talk about. If
you have some question about these 3 main aspects, what we want to know, to just tell you, because today we are few people working on ultrasound, and we try to show you all the work that we have done during the last 20 years. To make from a tool that it was, I would say, patient-based at clinical level, at bedside, to a tool that can be used also for measuring changing in clinical trials, whatever it is, the change. So our idea was really to demonstrate that what it is useful for patient in everyday practice, because it's considered a very good tool for evaluating if there is a disease activity, can also be used at group level in clinical trials. But for making this, we had to demonstrate that it was reliable and valid across machines, performers, I would say ultrasonographer, in every center, that everyone could see the same thing. Otherwise, you cannot apply an outcome instruments. And also to show how it was possible, working on all different diseases, to capture domain of interest that can be also useful and measured in a different way in some clinical trials. So our work was really to create a methodology that it is working on for ultrasound, to make it
But at the same time, so how to develop an instrument for a matched domain, to pay attention which are the problems of creating an instrument, which is the variability and other aspects, the bias in the study design and other aspects that should be taken into account if we want to have at the end a score, a number that is truth and reliable and discriminative. Once we have developed this in this our stepwise approach to apply to clinical trials. And then we are showing you, according to our stepwise approach, where we are in the development of this instrument for each the domain that we have chosen as a target domain in some diseases.
So no questions from Zoom? Sorry, was that a question at the back? No? No questions from Zoom. Okay, we'll move on. Yes.
Just my curiosity. In Canada, most of the rheumatologists have their own ultrasound machines. They do ultrasounds on hands. And, you know, I know in Canada, where I'm from, most of the rheumatologists have ultrasounds in their clinics and they're doing ultrasounds on hands. And I'm just wondering about the quality of that, like how well they are trained. They're probably not trained like somebody in a hospital is trained to do that. And I'm just wondering how that would impact your work.
So this is the way in which we can use an instrument for measuring eventually a disease activity. I guess that most of the ultrasonographers were trained, so they cannot, it is quite difficult to use an instrument if you are not trained for doing this. We are all rheumatologists, so it means nobody among us except Andrea is a radiologist. So we are all rheumatologists. Ultrasonography is a technique that can be used by no radiologists because there is no radiation inside. So gynecologist, gut. And I think that when you use for evaluating the activity of a patient at patient level, if you do always in the same way, you can be reliable with yourself. But then for being reliable with the other, we have to make other aspects.
But I agree that you have a point, but I think this is actually being addressed throughout the world, that it needs to be entered into the curriculum when you train to become a rheumatologist, because countries have different regulations to when you can scan and what documentation you need to have for your training. And that is not something that I think we can address within OMRAC, but there's coming more and more focus on it. And so I think that is definitely going to help. But I mean, there will be nobody controlling the local rheumatologist, but I agree with Mara that the greatest problem is whether he can find what the neighbor guy is finding, but he's probably very reliable with himself.
If I can add, because I'm also from Canada, and I think you raised an important point, is that I think when there is a good training, rheumatologists have been shown to be quite reliable. The problem is that it's not in the national curriculum and many programs are not training. And also local courses that we don't know what is happening and the competency level of people who graduate from courses. So I think these are very valid points, and development of good tools is really critical.
But I think that's also the way to improve the curriculum.
Absolutely.
It is to show that it is a valid
Absolutely.
instrument. And once you've shown it's a valid instrument, then it becomes more important that you ensure the training locally.
What we have tried to do at ULAR level is to work in parallel. So we have used our ULAR hat to develop education. At the same time, then within OMERACT, we were developing validation. And we end up in ULAR with a competency assessment curriculum that it is giving you the certificate to perform ultrasound, the certificate to teach ultrasound. So what it is quite nice. And it is a certification, not of attendance, but of level of acquirement, I would say.
So I'm not sure if anyone here has done a mocker on a patient, but do you have mockers to assess cognitive function? Yeah, you know, with the rhinoceros and I can't even think what it is, giraffe and the clock. So that's about an hour-long training course, and just about blew my mind. But, you know, often tools we use need training, even though obviously ultrasonographers need more than an hour. So this is the work of the CPPD group over the last few years, and I'll just present it in brief. There's my clicker. According to the OFISA four-step process. So step one was to look at whether it satisfied the EFISA filter. So a systematic literature review was done, which found that really there was a lot of heterogeneity with regards to definitions that had been published, and that there was some sensitivity and specificity data, but quite a lot was lacking, and there was very little reliability data. So we went on to do a create definitions through a Delphi process, and then undertake a reliability assessment, and found that, and came up with some definitions which have been published, and found that they were relatively reliable, particularly with regards to the hyaline cartilage and fibrocartilage at the knee. The other lesions, such as synovial fluid and tendons, needed more work. The CPPD definitions were then tested against for criterion validity against patients undergoing knee surgery, and found to be valid with regards to, again, hyaline cartilage and fibrocartilage at the knee. And sorry, there we are. That's the criterion validity. And so then we have done a patient-based reliability exercise. And then we have looked at a Delphi process to identify a scoring system for CPPD extent. So this is about developing the scoring system now. And we have agreed that, we examine the menisci and the hyaline cartilage at the right and left knee, the triangular fibrocartilage at the left and right wrist, and then we summate the scores. And that we have done a reliability exercise here on patients, and found that reliability was substantial to almost perfect most of the time, being occasionally fair at the triangular fibrocartilage. So next step is developing evidence. Step 4, developing evidence for EFISA. And
our stepwise approach, in which when we move to a disease and then to a target domain within a disease, we try to get the evidence. If the evidence is already in the literature that good definition works because they pass the EFISA filter, we do not do nothing more than apply and try to develop this. If there isn't, then we start to develop this definition. How we do? We ask our colleagues to send images of the definitions of what they do usually, and to describe what they are doing. Then we make a Delphi to try to be sure that everyone is looking at the same things. When we have created theoretically the definition with the Delphi consensus, we take all the images that they were taken, and randomly we give them, and we ask to apply to score them according to the definitions. And we test the definition on static images. When we can, we test also on videos. Then once we have validated this, because on static images, we have seen that they work, we move to the patient exercise. So we have patients with different, thanks to you all, with different disease spectrum, this different disease activity. Sometimes we put some healthy subject in, and we make this exercise to validate these definitions and this scoring. Once it works, then we move to the last step, that it is the EFISA filter. What it means that we have to apply in clinical trials, observational trials, to see if it is discriminating and sensitive to change. This is our stepwise. You know, it takes time sometimes. And we are doing this for everything. So when you see this kind of approach, you see step 1, step 2, step 3, with all the check where we are. So now we have this instrument. The instrument is ready. We have just to see if it works. So we have, if the instruments work, we have the score at the end.
so should we wait till the end for questions? Yeah,
We can do.
carry on. Yeah.
Then I think it was me that is just going to give an update from the large vessel vasculitis group. Oh.
Have you tried to use criterion validity as well? What do you use as the criterion?
It's depend on what we do. For example, for the CPPD, that the first we developed the reliability exercise on patients, and then the validity was made with the criterion validity, what was the histology. So they performed the ultrasound to the people that were going under surgery. Then they went the surgery and they just realized if there was a deposit or not. Sometimes it's against liquid, if we can. Sometimes it's just with the better proxy that we have. If we cannot have histology, we do not make MRI all the time, because not always MRI can see the same things as ultrasound. So sometimes first, eventually, because we do not have a 3D definition of the joints, okay? Like you can have by MRI, you can be influenced by some hidden part that we could not see on ultrasound. Also because there are some aspects that they are captured in a different way. So sometimes we use MRI, sometimes not, but we do not think that MRI is a criterion validity. It's still another construct validity, I would say. And but we try to validate also on longitudinal aspects. So we see if the disease is changing or whatever. So we try to make this in a different way.
Right. Okay, I am doing the update on the large vessel vasculitis, and we've just realized that we've popped around 2 papers, but it's nevertheless been done anyway. So for the large vessel vasculitis, a lot of the work has been focusing on giant cell arteritis with and without the involvement of the axillary artery. And so this paper was actually supposed to be this one. So there was a systematic literature review done based on the definitions. And then we moved to the next step, which was to test the relevant definitions, which was, oh gosh, was this one, defining what are the relevant lesions for giant cell arteritis, testing these, acquiring the agreement through the Delphi exercise, and testing the subsequent definition on static images and on video clips. And it was then followed up with the paper on the right side on a patient-based exercise, testing the reliability of those definitions in patients. And so based on the reliability, both on images and on patients, it was decided to develop a scoring system. And in a way, we then go back in the stepwise procedure. We then again do a Delphi exercise, getting people to agree on which scoring system do we want to use. Can we agree that these are the items to measure? Can we agree that the severity is going to be measured like so and so? Once there was an agreement, then the scoring system is tested on static images and no, that was only static images. And the next step is then to test the scoring system in patients. That is a little bit difficult because you need to have lots of patients with active GCA that are active at the same time for an exercise. And often we have 8 to 12 patients coming in, and that can be tricky to get ready for a 2-day exercise. So what we actually managed to do is to make this provisional OMRAC ultrasound scoring system for giant cell arteritis that was then tested on existing data images from Christina Ponte's Proteo study. And it was found to have sensitivity to change when tested on these data, and was also shown to have construct validity by having a correlation with CRP, ESR, and also the Birmingham Vasculitis Index. So the reason it's called the provisional one is because it's not been tested in patients, and whether we can actually do a proper exercise with having enough sonographers and access to a lot of patients that are sick at the same time is going to be a challenge. But testing the scoring system, as I said, on an existing data material looks very, very promising. So I think we are actually moving into this construct validity of this scoring system, and it is currently being tested in clinical trials for some of the longitudinal construct validity and the discriminant ability between treatment groups.
When patients are active, it's quite difficult to ask them to come and to lie all day. And we have to measure when they are under steroids, they are not well. So making a proper reliability exercise on patients is difficult. So what we decide is to test directly in a trial. They permitted us to do as a secondary exploratory endpoint. And so in patients that were treated, that we knew that they had a giant cell vasculitis, we performed ultrasound on them just to be sure if there is a sensitivity to change under treatment.
So what was also done when the scoring system was developed was that it was actually made available as an online tool. So this is the online tool on the right side where you actually enter the millimeter from the measured arteries into the tool, and it comes up with a score. So this is the scoring system. You enter the right and the left common branch, and then the parietal and frontal branch and the axillary branch, and it can then look like this: what is okay, what is pathological, like this, and it comes up with a score at the end, taking into consideration the number of segments that are available. And you can say, why are there not all segments available? If there's a biopsy's been done, then it's actually not really accessible, and so maybe that segment cannot be included. So it takes that into consideration. But there's a QR code and it's available online, and I heard from a reliable source, quite useful and very easy to use. And I think that's really quite a nice result of that, that scoring system.
To take the say you can say because you have the more.
What do you want me to say? I don't know what's on your mind.
I was just telling, congratulating with, although they are not here, the people, that a lot of work was done for that. And I think that we are really trying to make an instrument that can substitute the biopsy, the artery biopsy, that can be reliable, that can be applied to several segments, because sometimes, of course, we make the temporal biopsy, but probably we can see better in the axillary that we cannot take the biopsy of this because the temporal artery are not involved. So I guess that this is something that can be very useful and also very, very important for trials, but also for practice.
That's true. So basically, the group is working currently on the step 4, developing evidence, and I hopefully think that those data would be ready for the next DOMA Act.
For assessing treatment response,
No,
or is that for diagnosis?
That is for diagnosis, but you can use it for treatment response as well.
Okay. Right.
Okay. Then it's the Sjogren's syndrome group, and that would be you, Nevzim. Thank you.
Okay, so for the I represent the OMERAC Sjogren's subgroup studies update I will give. In the first step, we did systemic literature review to determine the elementary lesions of the salivary gland ultrasound. And after that, a scoring system developed with these determined elementary lesions, and it was published. After that, both on the static images and also on the patient level, agreement and the reliability exercise was performed and published again. Another reliability study was performed on the abnormal vasculature of the salivary glands. And this reliability exercise also developed, a scoring system developed according to this abnormal vasculature in the salivary glands. For the assessing the construct validity, we assessed the construct validity to compare the umbilical ultrasound scores with the MRI scores, as well as we use unstimulated whole salivary flow rates to compare with the ultrasound scores. In this exercise, we accepted the score 2 and above as the pathologic gland pathology, both in the ultrasound and MRI. And in this table, you see the results of the agreement between ultrasound and MRI, which is moderate and good between the ultrasound scores and MRI, as well as in unstimulated whole salivary flow rates agreement between MRI and also umbilical ultrasound scores also moderate, showed the moderate and good agreement results, both in the parotid and submandibular glands.
Sorry if I interrupt you. You see in the MRI, when can you go back? When you see the validity against MRI, you see that it is much better in the parotid, that is more accessible also by ultrasound, than in the submandibular, that you can see much better with MRI, not so well with ultrasound. So you can see that we cannot consider that if we do not reach excellent agreement, is not because we do not see, we are not good. It's because we do not see what all the things that you can see. So it is for us quite difficult to find a construct against which we have to validate. So we use several constructs.
Okay.
With the 3D ultrasound, you lose at the moment. You lose the fact that you cannot measure the vascularization very well. And also, since we are looking at very high resolutions, the resolutions of the 3D is lost because we are looking at the morphology aspects sometimes, especially with the salivary glands. And it is not so good for...
So for the step 4, we plan to assess the criterion validity of the new umbilical ultrasound scoring system. With this aim, we plan to compare with the biopsy, parotid gland biopsy results and ultrasound scores. But for this purpose, first of all, we should find the safest and the feasible method to take the parotid biopsies. For this purpose, we did 2 studies on cadavers. On the first study, we used the high frequency probes to determine the facial nerve free area for the biopsy. So in this image, you see the entrance of the facial nerve to the parotid gland. And in this study, 9 rheumatologists carry out the biopsies from the parotid gland. These core needle biopsies guided by the high frequency ultrasound, and you see the results on this graphic. As you may see, the rate of the success, which we assess with the presence of parotid gland, it's around 77%, and just a few samples include the nerve and vessel, which shows the safety of the technique. And also we did another study again on the cadavers. At that time we used another technique a safety zone proposed by the Italian colleagues in a recent paper, which is just beneath the earlobe, just 1-2 centimeter beneath the earlobe. So we use this safety area. And the results of the second techniques also comparable with the first study. And even in the second one, we get less number of gland tissue and more nerves tissue was present in the samples. So both techniques has the comparable results, but it needs standardization. So before we use these parotid gland biopsies for these criterion validity studies, I think we should standardize the biopsy techniques first, and then we will perform this study for the criterion validity of the ultrasound scoring, new ultrasound scoring system.
Thank you.
So what you see, we can also use ultrasound that you will see also on Friday morning as a tool for helping to retrieve tissue. This is very clear in the, I would say, in the synovial tissue now. We are taking also tendon, we can go to the salivary glands, and probably we try to see if we can make safer biopsy, and we can make biopsy is probably more interesting glands, because we always think that the minor salivary glands are a representative of all the involved glands of in the Sjogren syndrome, but they are probably some glands that can show earlier disease or whatever. And I think that all of these aspects can be also discussed tomorrow, I guess, that at 3 when there will be the Sjogren domains and some of the aspects, because for making diagnosis, either you have the autoantibodies, either you have the histology of the gland tissue. So, and by ultrasound can be used for helping in the histology, but also for graduating the involvement of the salivary gland, what we have already done. Now we just make together a small overview of the synovitis and enthesitis that I think that they were the all validated tool, in which we hope that we convince the few people that they are not ultrasonographer here to agree that we have done whatever we could have done for validating ultrasound in for synovitis and enthesitis. Just this is another way for showing you that for these both two elementary lesions, we have passed all the steps, and including the OFISA filter. So for the enthesitis, we have defined, we have made the systematic review, we have defined the lesions, and we have created the scoring system. We have done the same with synovitis. This was our first attempt to create a scoring system. Now we are much faster. We take 1 or 2 years because we need also some times for validating a patient. With the ultrasound score for synovitis, we take 10 years. And what it was that thanks to this big effort, we could develop the stepwise approach, because we understood by our mistakes to do not define the lesions, that we were not reliable and we were not applicable to patients. So we didn't understand how we had to do this. And so we just restart from the beginning, and we created this standardized approach that was then helpful for everything. In this scoring, you can see that we use both the grayscale and the Doppler together independently. The higher score gives the higher information on the activity. Why we did this? Because not all machines have the same quality of the Doppler, but they have almost the same quality in the ultrasound and the grayscale. So the portable machine, the higher test machines, in that way, combining together the information allowed you to do not take into account the variability to the machines. This is a scoring system, a patient joint level that can be applicable to all joints. And making the sum of the most severe synovitis grade, you can have a number at patient level. So like that it is giving you a score. And what we have done, the first things that we did, it was to test this in an open label study under treatment, the abatacept. We tested the sensitivity to change of all the elementary components of the synovitis score in patients with rheumatoid arthritis treated with abatacept. You can see that the ultrasound was able to show the responsiveness starting from 1 week in the combined score in the Doppler, 15 days for the ultrasound synovial hypertrophy, and 1 month in the effusion. So we decided, taking this, that effusion is not a main aspect of synovitis, but it is the synovial hypertrophy in grayscale and the Doppler. For matter, we have to say that in this study, also the DAS28 was able to discriminate these patients are responsive starting from 1 week. But when we were looking at the clinical meaningful DAS28, when the patients were feeling well, it was 1 month. So with ultrasound, we were able really to say that it was useful. One of the critique when we presented this in 2016 in, or 12, I don't remember, 14 in Budapest, no, 16 in Budapest, 14, yes, because then it was published exactly, in 14, that they told, yes, but it is an open label. So we do not know how it works against placebo. For sure, you were knowing that it was under a treatment, so it was sensitive because you knew already that the patients were treated. So we took some time and we made another study in psoriatic arthritis because this is a scoring system for synovitis, whatever it is the disease. It's not synovitis and rheumatoid arthritis. We develop in rheumatoid arthritis, but can be applied to every disease. So what we did, we applied this scoring system in a secukinumab against placebo randomized trial in psoriatic arthritis patients that they were active. They had to have active disease, active synovitis also at the entry. And our primary endpoint was the change in gloss at 12 weeks. The secondary endpoint was the SPARC, so the anxiety response, and the exploratory response was the Omeract ultrasound anxiety score. To do not make the study too heavy, we didn't include the anxiety score as an entry criterion, because otherwise it would have been difficult to include patients to have ultrasound synovitis present and anxiety synovitis. We selected the patient with a clinical anxiety and we treated them. If you look at this, we were able to show our primary endpoint in synovitis because the synovitis score, the gloss, was able to differentiate between placebo and active treatment. And starting from 1 week again. So we were statistically significant different at 1 week. And at 12 weeks, we reached our primary endpoint. And you see that also the placebo patients that were then put under secukinumab were able to show the responsiveness that was shown over the time. Then we try to see if our scoring, Omeract scoring system for enthesitis was valid. The problem was that since we didn't include patients based on the enthesitis, we didn't have what it was for us the main criterion, the vasculitis, the vascularization, the Doppler signal. So we create preliminary definitions based on grayscale abnormalities and or Doppler. Based on this, we just showed that also the enthesitis score was quite valid. It was able to differentiate between placebo and control and active drug for the first, I would say, 8 weeks. At 12 weeks, we don't know what happened. 2 patients were out. And despite we asked if they were sure that there was something like that, because there was really too aberrant, this data, this is what we obtained. So we didn't obtain that we were able to differentiate at 12 weeks between placebo and active drug, but as you can see, it shows nicely the responsiveness and the difference between the 2 groups. Then we ask, can we use ultrasound for selecting patients? Because of course they are all active, but then probably the patients with ultrasound data are more active, and probably they are the people that respond better to treatment because they are truly active. We use a cluster analysis and we identify in this population 3 clusters of patients that, if you can see, they are almost the same, except that cluster 3 had more tender joints, more swollen joints, higher VAS pain and patient global assessment. And also the physician thought that they were a little more active, including the C-reactive protein. When you look at the ultrasound distribution at baseline, cluster 3 was really severe as cluster 1 and cluster 2 less severe. Importantly, higher disease activity and more severe synovitis in these two clusters, and cluster 3 show even more higher inflammation with PD, so power Doppler. So they were really inflamed, cluster 3. When you look at which joints were involved in these 3 clusters by ultrasound, we found that the synovitis was most frequently affected, presented in MTP, MCP, and wrist in cluster 3 and 1, as compared to cluster 2. Cluster 2 were the oligoarthritis, big arthritis, not small. And cluster 1 had a higher frequency of synovitis in the elbow, knee, and the ankle compared to cluster 3, but lower in MCP and PAP. So ultrasound show us that despite PSA as a group where all active, all swollen and tender joints in CRP, we can identify 3 different category of patients with different involvement in synovitis. One probably more enthesitis, lower joints, some with more polyarticular, like a rheumatoid arthritis distribution, and the other like a typical psoriatic arthritis. When we were looking at the gloss changes, so the difference between placebo and treatment in these 3 groups, in all, you can see the difference. In cluster 1 and cluster 3 was rapid and quite effective. In cluster 2, they were not differentiated. So it means really that probably, or the joints that were seen as swollen at the beginning, they were probably osteoarthritis or whatever, or the disease activity was driven by other aspects than ultrasound, that synovitis. This is quite interesting because I think that it can help us in identify better the disease activity and eventually better including patients in the trial. Do you have any question? So based on this, we have finished. We do not test anymore. No question?
Hello, everyone. I'm Elfita Sabudin. It's a pleasure to be here today. I'm presenting on behalf of a very large group. So we have 24 collaborators, and this project started about 4 years ago when I was a fellow. Can you hear me okay at the back? Okay. Just a little bit of a background. We have a lot of ultrasound studies, and we talked about a lots of definition of what appears to be pathological. However, over the last 10 years, the ultrasound machine that we have is really good at detecting any changes which may be present in healthy individuals. So now we have a question. Actually, if we want to target remission, what are we talking about? So Mada mentioned about synovial effusion is less relevant when monitoring disease activity. So in this study, we're taking a step back and to reassess rather, what is normal versus abnormal within the ultrasound context. And if you want to put it in the OMRAT language, if you like, that's where we sit. So the main overarching question is, what are the ultrasound findings in healthy individuals across the age range? We're very delighted that 24 recruitment centers, all from OMRAT, joined the study. And we wrote up the protocol based on the ultrasound score that OMRAT has developed. So this is the timeline. The data was collected 2 years pre-COVID. Throughout the process, we noticed that there are large discrepancies in some of the joints. So that would be the MTP, the toes, and the wrist joint. And because you probably noticed that in the atlas that we showed earlier, those sample joints are mainly in the fingers, so MCP and PIP, rather than the toes and the wrist. So what we're doing now at the moment is I'm regrading about 10,000 ultrasound images. We're on number 7. We've done 60% of it. We successfully published our tendon paper last year, and that's in ERD. And obviously it's a long journey, but we're very hopeful, 0.789 within this quarter of the year, hopefully. And I'd like to extend my acknowledgements and thanks to all of our healthy subjects, sonographers and centers, and particularly the fellows that recruit and scan all these healthy subjects. So this is just to give an idea, 954, and we have quite a good range age there, with a median of 43. And this is just to show the variability that we have. So grade 0, 1, 2, 3 is nothing seen, a little bit, some changes, moderate changes, significant changes. And this is across the age groups. So watch the space. I'm very hopeful within the next 4 to 6 weeks, I'll regrade the remaining 4,000 images at home, and then we can start analyzing the data and present. And that's it.
Just for telling, this minimal disease activity or threshold was answering the question that was asked to us when we were in Pine Arts. Okay, great, because we made a first attempt to apply the OMERAT scoring system to healthy subject, 200 unique cohort, and we showed that the OMERAT scoring system for synovitis was quite good because people healthy didn't present any abnormality except in the MTPs. And they told us, this is a cohort of young people. We can be sure that these lesions are not present in the age, for example, of 50 when rheumatoid arthritis happen, when there are a lot of osteoarthritic changes. You can be sure that it is so sensitive that you are capturing active disease and non-other abnormalities. So we made this European study in which we recruited almost 1,000 healthy subjects from 18 to 86 years old, according to all the range. And we applied the Euro-OMERAT ultrasound scoring system to wrist, MCPs, MTPs, PAPs, so the joints that usually are involved in the arthritis, like rheumatoid arthritis, to be sure that when we say that there is an abnormalities, is a true abnormalities, because an healthy subject cannot have these lesions in these joints. Probably just based on the first attempt, we excluded the first MTP joints that can be always the location of osteoarthritis with some inflammation, something. So we cannot treat a patient as having an arthritis if he has an osteoarthritis, need another treatment. So this was the goal of this study. One thing is that at the same time, we examined the tendons. And what I can say, what it was, Ilfita was telling, it was published last year. Tenosynovitis is a marker of inflammation, so disease, because healthy subjects do not have any tenosynovitis. So when you perform ultrasound and you have a tenosynovitis, you have a disease. Whatever it is an arthritis. Can be a psoriatic arthritis, a rheumatoid arthritis, whatever it is an arthritis, but the tenosynovitis is a disease. And it is a quite good achievement because I think that we have done also this. So now the question, according to you audience, we are not asking to vote on that. Do you think that you need additional data on validation before we can suggest to put the synovitis score and the enthesitis score in the core set of instruments that can be used usefully in clinical trials? We have demonstrated that they are valid, they are reliable, they are sensitive to change, they can discriminate between treatment, between groups, and against normal subjects. Enthesitis also, somehow, yeah.
Did enormous amounts of good work, so that's great. Can you just say that because you have it in one disease and it also works in another, is that a general imaging thing that it's fine to say that enthesitis works in different diseases where it hasn't been, where you don't have the complete set of validation?
We are speaking about synovitis. So synovitis we have developed across 2 diseases, and we have also applied to every other diseases. For example, gout, for us, synovitis, we applied the OMERAT scoring. This is a scoring for synovitis.
So just to understand, so it's in your mind, it's I don't disagree, it's not that, but in your mind, you think that it's a score of synovitis in, you could say, MRI or ultrasound could be, doesn't matter whether it's same, but enthesitis, you're not arguing should be core instruments of RA.
Enthesitis should not be used for RA. Enthesitis was developed for PSA and SPA. And
Right.
in longitudinal trials, observational, whatever, also in clinical practice, it is applied for this. And
Okay.
we use this also for discriminate. Then you can say, can we use antizite in athletes? Probably, I don't know. We have to validate, but I
Yeah,
would
there
say
you
that
probably would have to validate, wouldn't you? Because it could be
this
other
has
things in
been
principle
validated
because-
against, I would say that there are cross-sectional studies making traumatic enthesitis versus inflammatory enthesitis, and that they show the difference in between the two. So the discriminant validity among the groups. So from a question from me to our patients. Do you think that based on this amount of work that it was a lot, do you think that is a feasible tool you would accept to be examined by ultrasound? Yeah. Do you think that we have shown enough data to show that not only in clinical practice, patient-based, but also for trial, it is a good tool that show the discrimination, the sensitivity to change, and also I would say that can be used comfortable as a measure of a target domain like synovitis, so like inflammation in trials. I think that was also a question. No.
No.
So you're not comparing ultrasound to other instruments, because you're not asking us if no. So given that, and given that ultrasound is very low burden as far as what a patient has to endure for the examination with the ultrasound, I don't think you would meet a patient that would have a contrary feeling. If it's sensitive, it's reliable, it's discriminative, and it's comfortable. It's low burden. It's a no-brainer.
Okay, so at least we have the blessing from the
I do have one question. As far as the variability, because my head keeps going back to the variability with the training and calibrations and things like that. How often is that done within clinics and whatnot? I loved everything, but that's where my head keeps going.
How we do? Usually for developing the scoring system, we make a lot of calibration. Okay, we test with the same machine, with different machine, with the acquisition, the position, the reading, and whatever. Now in clinical practice, what we do not make each time that we make an international study a reliability exercise. But what we do is we create an atlas, we make a training session on patients, we ask that they have a good machine and a certification that they know ultrasound. For example, for the ultimate study, they should have had the Euler certification. So we ask for that, or an equivalent certification, for example, the certification made in the United States, the sonar. Then we ask at the screening to send the images of all patients with their proposed grading. We read centrally all this. If we agree with the grading, they were allowed to continue. Yeah, it was.
So again, when I do clinical trials with the pharmaceutical industry, I have to learn how to do a mocker. I have to learn how to do a SLED eye. You know, I have to get accredited in all these outcome tools as well. So it's standard in clinical trials to do some validation work before you start scoring.
And what we do when we include centers in Denmark, for instance, that don't do lots of projects, we actually do an image exercise so that everyone agrees that the score is the same, just to make sure that everyone's on the same page.
So practically, though, as a patient, where I've had a resident come to do the ultrasound, followed up by the rheumatologist who repeats that same ultrasound, I can tell you physically that there is a difference in perception of amount of pressure that is applied, angle, etc. And then the conversation between the resident and the rheumatologist is, oh, well, you know, try doing it this way, try doing that way. The comfort that you've provided here and saying, but they still have to send their images for validation to somebody who reads that independently. They are validating those scores that the person has submitted. But if they haven't applied the transducer head at the right angle with the right pressure, then you're not going to get the same quality of the image.
Exactly. So what it is, you are touching the right point of the variability on ultrasound in the reading, in the interpretation, and in the acquisition. When you want to learn ultrasound, we know that the learning curve, one of the first studies that I performed when I was young and starting to validate ultrasound, it was how many examinations do you need to be reliable when you're starting from scratch? Okay, how many ultrasound, for example, just for synovitis of the MCP was that 70 examinations, just to start to be reliable, 70 patients, 70 and all the MCPs. So it means that what we have calculated that a person to be able to scan alone needs 2 years. So the training should be done during the training as a fellow, because if I trust my fellow that is doing well, he has already done 2 years. And you are also touching a point. When we perform the reliability exercise of the training for teaching ultrasound, all the patients say to me, doctor, they don't press in the same way. They don't do the same. I don't know what they have written, but they didn't see. Exactly. So what we try to do is how to make, so we have also standard for this. For example, for being sure that there is no Doppler or there is Doppler, we should see the gel in the images. It means that they have not made so much pressure, okay? We ask to make videos. So also the videos help us more than the static images, because it is telling us that they are not just taking like this or like this, but they swap the joint. So we are trying to make it. By doing this, they learn. And what we have learned by standardizing, we are teaching now in our course. So it's really a continual learning that is making the teaching of ultrasound much easier, also as the learning of ultrasound and the validation.
I know it's a little provocative, but often when we send in the ultrasound papers, they ask for the intra and intra-observer reliability for those who are doing the assessment, but nobody ever asks for the inter and inter-observer reliability for joint assessment, which is the cornerstone in rheumatology anyway. So nobody ever asks for this. They assume that all the clinical exams that don't ask anything about that, but for the imaging, were they reliable? Whereas the joint assessment can be like completely. So being an ultrasonographer or whatever, rheumatologist performing ultrasound, sometimes you get a little bit fed up with that inter-reader reliability because nobody asks us for anything else. So, but we do tend to provide it because they ask for it.
To say some things about that is just that at the beginning, when they was developed the swollen joint count or the tender joint count, they tried to make reliability exercise. They were so bad. They were not able to improve that they decided that it was not needed because it's a clinical, physical ability of the doctor to make it. So you do not need to be tested for this, but they tried, and there are papers in the 70s based on that. Yeah. Some other questions, some comments? So our question, do you think that we can ask that our instrument, our ultrasound score for synovitis, eventually for enthesitis, can be included in the course setting, which people can pick up an instrument to evaluate it at target domain? We are not asking the home actors to vote. It's just like a discussion, or if we need to make more evidence.
So you're asking, couldn't it be a tool in the toolbox?
Yes.
Not that it's prescribed, but can 100%.
So it means you agree? Probably we can we'll raise the hand. I like this.
Yeah, it's more of a question. It's just from this morning's presentation. Do the regulators have an opinion on that?
So
FDA?
I think that I don't know if FDA is interested in knowing which instrument can be used, but I think that Philip or Miguel can answer better to this when you try to put MRI in the, but you wanted to use MRI as a response criteria, not as a tool for evaluating. I don't know what you try to did. Miguel.
I didn't understand the last part because it was as an outcome measure in trials, which I also think is a question here, right?
Mm-hmm.
I'm not an FDA expert at all. I think there's not always so that because we can agree and you can say we have the data to support that that it's doable.
No, it's not. I'm not asking if it is an outcome measure. I'm asking if we can measure as an instrument. What it is different. Once we demonstrated that several outcome measure can be comparable, you can use just this as outcome.
I think the question was what FDA thinks about this.
Yeah, but
so that and then you asked me to answer this, and I say that FDA do not always. Even when you've decided on an MRI or an ultrasound tool, that they thereby think that it's can be used as a primary outcome, but that shouldn't keep us from showing that things work, I think.
I think there's a diverse answer to the question. One is we still haven't seen a registration study that uses an imaging, a modern imaging outcome as the acceptable primary endpoint for FDA. I don't think it's out of the question that might happen. To me, the great benefits, the question is, what limits studies often for FDA is the size of the study and the amount of toxicity. So often with pharmacological therapies, they want a certain size phase 3 because they get an idea of toxicity. These tools, to me, and by that I mean ultrasound or MR, are great for telling you if you've actually got a response. And I could tell in a very small phase 2 trial whether I've got a drug that's worth investing in.
Yeah, what we have done.
I don't normally recommend, Mikkel hits me for this because he doesn't like it, but I don't normally recommend these for large phase 3 trials imaging because it's a lot more cost and trouble doing it in multiple more sites to get the data. Can it be used for phase 3 studies? Absolutely, it could be used if you're willing to go through the extra expense as a company. But at present, there's no great advantage for them for FDA. There's a third part to the question, which is, does FDA accept this methodology for what we've done? And Dorcas and others are doing things now with FDA and their production of tools to make sure that the MRAC process is more aligned with FDA, which is something we should have been watching for years, because FDA has very clear ideas of what it likes, and you have to do things according to our methods. And we're looking at the alignment of the filter with the FDA process, and it's not far off.
I just would like to add, you can use ultrasound as a proof of concept tool. So in phase 2, it works, it doesn't work very quickly, but you can also use in phase 3 clinical trials for reducing the number of patients that you want to do. And eventually, if you select well your patients and you are pretty confident with your drug, you will have a very nice result in the response, much better than against placebo, I would say.
A question. So you're talking about ultrasound as an outcome measure, as a primary or secondary outcome. Do you consider using ultrasound as a tool for including patients in study, or this is just a broad statement that, no, whatever?
I was based on the cluster analysis of our ultimate study, I think, and also, but what it has been already demonstrated with MRI in rheumatoid arthritis, I think that imaging is a very good tool for selecting patients entering in a study. If you want to have an information on the response on the activity on a target domain.
In relation to it being used as a primary outcome measure, and following up on the comment about what FDA might feel about that, from a patient perspective, I would be much more confident knowing how poorly discriminative a patient-reported outcome measure is, in my experience, for reflecting the change in my disease status. And the total joint count and the joint counts at all, how they don't seem to be related as closely to my disease status as the ultrasound. I mean, would that factor into the FDA making a decision about using it as a primary outcome?
That he wants to.
We love to hear this, but unfortunately, FDA is FDA, and they're very based on precedent, and signs and symptoms is what drives them. They change at the speed of glacier, actually much slower than glacier recession. What's very interesting in the studies that have looked at, so the DAS is a common tool used, especially in Europe, which is a formula that includes a number of different variables. And when you look at the DAS formula versus MRI, or the DAS formula versus ultrasound, you find that the elements that drop out of DAS are the tender joint counts, the patient globals. So, and the things that rheumatologists largely drive their drug prescribing is swollen joint counts, because they're trying to find your synovitis when they examine you, and the CRP or the ESR. So the objective measures of inflammation drive drugs. But those concepts don't, you can do a modified DAS that's much closer to objective inflammation. And the concept of collecting a whole lot of other patient-reported data, I like, but then we have to do something about people's pain and fatigue and all the other things that we should be collecting that give a comprehensive view.
Make a comment and eventually a provocative question. You have a drug that probably make you feeling very well. Could be morphine or steroids. You feel completely well when you take it, but then your joints or your disease is going worse. So I think that we cannot just use the feeling that your disease is doing well if the disease is not doing well and you are accumulated side effect. I think that what can help us, this kind of studies with this kind of tools that permit to see the true disease activity and which is linked about your status or your pain to the inflammation to other aspects, is to drive, I would say, pharma also to think about drugs that they are effective and control also other aspects. Or if they are not able to control the fatigue, the pain, probably they are not linked to this inflammation, but other things that we have to explore better. I would say that it's much better to understand what it doesn't work, how we can change, instead of say, okay, you are well. Otherwise, we go back to 50 years ago when the rheumatologist didn't have anything. I was saying, how do you feel? I feel well. Okay.
Can I just
continue like this?
Sorry, Alison, you were saying you had more confidence in the ultrasound than PROs. Yeah.
If you understood the contrary.
No, absolutely the opposite. So for example, no, 100%. If you look at the hack, the hack titrates my dose, okay? But the hack, one, I'm a vegetarian, so I don't cut meat. Two, I don't, we have a card that has a push-in handle rather than, so that's irrelevant. Three, it says open a milk carton. We don't have a milk carton. We have a twist top. There are so many elements. I have a daughter who also has RA. She struggles as the same way I do with RA in answering the hack. The angst associated with trying to figure out in our own minds how to answer that question that is not pertinent to our situation and yet affects the titration of our drug, I'm much more confident in using
You are the best
imaging
partner in this group. You are our. I know. It was a joke.
but but also recognizing that there are issues related to
feasibility for us
and variability, but they're being addressed. So, and I think there's way more variability in the things that are already accepted.
Yeah,
so let's move on.
Great. So do you think how we do engage clinical research to utilize these tools?
I've been thinking about this question a lot lately, and especially from a US perspective, where I don't think we've adopted ultrasound in the same way as our European colleagues. And what that means for me at my stage in my training is that I'm not well trained to do ultrasound. We're getting better. My program has hired a faculty member that's an ultrasound expert, and we're building our curriculum. We're starting to get fellows to train in US sonar and the equivalent ACR Room US program. But that's only starting to permeate fellowship programs in the United States, and I'm going to be in independent practice in about a year. As it specifically relates to Sjogren's, there's even less training. So if you have any ideas, I'm all ears. And so, I'm looking to mentors, across the United States to begin to get piecemeal ultrasound and training and to assess salivary gland pathology. And that's not trivial. And that's not an official training program. And so we need to find training programs with appropriate credentialing if we want to use these tools in both in clinical practice and as clinical researchers in the United States. And our European colleagues are way ahead of us.
I just to give the president of Sonar to answer, but I just would like to say that at the beginning, also in Europe, we were obliged to pay our training until everyone was almost trained, and we included the curriculum of the fellows, for example, in Italy and in France and in Germany, then and in Denmark. So then they start to learn ultrasound with the training. It takes some time.
So I'm Karina Tarava. I'm actually the president of US Sonar. And it's been my responsibility since the end of COVID, actually, even during COVID, to keep the education running. One of our biggest problems is all the costs for training have gone up. So we're trying to tap into different resources. I'm actually the one in charge of all of that. And it's not an easy task. But when I did the study in 2017, 97% of programs were actually incorporating ultrasound. The problem is it's not just on our side, it's also on the side of the division chiefs. I've been division chiefs. There's a lot of attrition of faculty. They can't retain faculty. So it's a multifaceted problem. Sjogren's, vasculitis, and stuff like that, that's all going to start this summer and next spring. In fact, we're co-sponsoring the vasculitis course with UW.
We're short on time, so I won't elaborate, but I'm very happy to tell you the Australian experience and how we've begun to deal with that problem of competency and then maintaining competency. So we can chat later.
And the other things is, do you think and then eventually send us an email about the question 3, how to validate our other tools. So for example, the large vessel vasculitis, the Sjogren, what we have done already that we have to test in trial more quickly. If you have some idea, please send us that I think that can be helpful to have all these instruments that can help, and they can also, we can also learn how to improve this instrument because they are not static. They have also to change in somehow. So said that, I would like to thank you for being here. They were not so numerous, but very active, and thank you very much. And I think that now we have to move to the we have the sessions house. And thank you for having taken all filling all your presence. Thank you very much.